Good day. My name is Christopher O'Brien. I'm a master's level certified addiction professional in the state of Florida. I've worked in over 20 treatment centers. I've seen some 1,500 clients over the past 20 years. One of the great challenges in today's society is what is termed the opioid epidemic. Included in the dialogue are such terms as the war on drugs, the treatment industry, and the word addict. With the goal of better helping those afflicted with the problem, I will attempt to challenge your thinking on the topic of addiction, and as a result, improve our ability to help those so afflicted. How about this idea? There's no such thing as an addict. As outrageous as the idea seems, challenging the use of the word will force us to look closely at the crisis. In this effort, I suggest we'll come to a deeper understanding of the crisis and propose dramatically different and more effective solutions which will save lives. There's no such thing as an addict, you say? What are you, crazy? Yeah, you and I will use the word, but looking at its use can form the basis for an entirely new look at the disorder itself. So let's begin. We can't discuss this topic without resorting to that volume, which is one of the best-selling volumes of all time. It's a basic text of a fellowship or program which might be characterized as the greatest cultural revolution in the history of mankind. At present, there are estimated to be 2.1 million people in this one recovery fellowship alone. For centuries, ethyl alcohol has enslaved and victimized humankind until a group of men came together and found a way out. Although the title of this book is Alcoholics Anonymous, it was originally planned to be named The Way Out. Although this book can't be considered a peer-reviewed or scholarly source, it's a self-report of over 100 persons, and it proved itself for almost 80 years as the basic text. Notably, Moose and Moose, a peer-reviewed and scholarly source, conducted a 16-year study with 628 people, in which 66% of the persons presenting with alcohol use disorder severe and who had active participation in AA were abstinent at 16 years. That is, 2/3 of the people who had an active program were abstinent at 16 years. That's perhaps a greater recovery rate than any treatment center that we know of today. But back to the volume Alcoholics Anonymous. I refer the listener to page 64, pretty easy to find. And on page 64, just after the third step and before the fourth step, it says, our liquor was but a symptom, so we had to get down to causes and conditions. Therefore, we started upon a personal inventory. So they're saying that the liquor, the drug, is a symptom and their underlying causes. So the question for us is, are there other sources that suggest there are underlying causes that the liquor or the drug is just a symptom? So let's take a look. So AA says that liquor is but a symptom. But what about mental health professionals? Offer the DSM-5, the Diagnostic and Statistical Manual of the American Psychiatric Association. This is the volume which, by practice, by insurance regulations, and by law is used to diagnose behavioral disorders. Let's look up addiction in the index. Addiction. See substance-related and addictive disorders. No such thing as addiction. And by the way, you look up alcoholism, it's alcohol use disorder. So the professional communities refers to what we might term addiction as substance disorders. It's interesting to note that across disorders, regardless of the substance, the qualifying criteria are reasonably consistent. This would again suggest that the drug, alcohol, cocaine, heroin, methadone, or even Suboxone is not the problem, but a personal attempt to cope with the underlying problem or problems. The substance is just a symptom. So we had to get down to causes and conditions. But what about government? Substance Abuse and Mental Health Services Administration, SAMHSA, offers a free volume on substance disorders. And it says it defines co-occurring conditions associated with the disorder. That is, those conditions that are associated with the disorder. It's a pretty thick volume, isn't it? The title in itself contributes to the idea that the substance, the drug of choice, is only part of the problem. But specifically on page 26, early in this volume, the Substance Abuse and Mental Health Services Administration states, a person with COD, co-occurring disorders, may also be a mother, a plumber, a pianist, a student, to cite a few examples. What they're saying is, when you call someone an addict, you're putting them into classification. And because the substance is just a symptom of the problem, each person's problem is different. And it's not just the substance. If you just take the substance away, you still have the problem. So in the case of substance disorders, recovery fellowships, the American Psychiatric Association, and the Substance Abuse and Mental Health Services Association agree that the problem is much more than a drug problem. They all assert that the substance is not the primary problem, but a symptom of the underlying problem. If we address the underlying problem, we might more effectively assist the person achieving long-term recovery. So AA says we got to get down to causes and conditions. SAMHSA talks about co-occurring disorders. But what are these co-occurring disorders? That's what we need to know. If we know what they are, we can treat them. To get more specific, we look at another clinical volume, The Addiction Treatment Planner by Perkinson and Jongsma. Some refer to this as the Wiley book. The cover suggests that it directly addresses 44 behaviorally based presenting problems. If you walk into a facility which treats substance disorders, they will undoubtedly have on hand this publication. Of course, we can't review all 44 items on the list. So we're going to select some of those which will support the points I intend to make later. Adult children of alcoholics, childhood trauma, dangerousness, lethality, grief and loss, unresolved legal problems, parent-child relationship problems, and suicidal ideation. Allow me to repeat my suggestion. There is no such thing as an addict. That which we call addiction is a symptom of core underlying problems. When we more clearly identify these problems and offer solutions, we gain the ability to free our loved ones from the prison which pharmacological technology has inadvertently created. We must remember that all the books we have offered here are the result of experience and studies of people. In the same manner, I come to you emotionally motivated by my experiences with people. It is by listening to people, carefully listening to people, that I strive to understand. First, I try to understand in an effort to help them. What I discovered is the first element in this healing process, to be understood. There's a special healing connection with our clients when they feel that we understand them or that we just care. For this reason, I peppered my treatment manual with some of the most profound and revealing statements from these people. To many of you, these statements might seem remarkable or even outrageous. While you and I might have difficulty relating, people with substance disorders and those in all stages of recovery are likely to relate strongly. I will suggest that these statements by people will come together to better describe their condition and more clearly define a superior method of treatment. As I refer now to my treatment manual, I want to make it clear that I didn't come here just to create problems. I came here to help to understand the problem better and propose valid solutions. Page 10. I ask female clients, so what do you think is your destiny? My destiny, she says, I think it's my destiny to die of a heroin overdose. Page 18. I ask a young man, 23-year-old male, what is your drug of choice? His answer, what do you got? 21-year-old female. When I hear that someone died of an overdose, the only thing I can think of is where can I get some of that shit? This is a young lady who, at the age of 9, came home and found that her father had committed suicide. 26-year-old female. I'm not afraid to die. I'm terrified of living. 23-year-old male. This was after his 6th near-fatal overdose. He actually was placed into treatment. He smuggled drugs into the treatment center, overdosed in the treatment center. I was called. I went to the emergency room where he was there still on IVs, and I looked at him and I said, so do you want to die? His answer, no. But after a long pause, he said, but it'd be okay if I did. 23-year-old female. It's not that I want to get high. I just can't stand the way I'm feeling. And we now know that a lot of people continue to use, not because they're getting high, because they're terrified of the withdrawal. 50-year-old male. I remember my first drink. I remember thinking, this is the best I've ever felt. 25-year-old male. Counselor, what was your first drug? Young man, Adderall, age 6. I loved Adderall. 34-year-old female. When did you pick up your first drink? 14. I was 14 when I started drinking. So, what was going on at the time? Going on? What do you mean? I don't know. I'm just curious. What was going on at home? Oh, yeah. My dad left us when I was 14. But what does that have to do with anything? So what do these statements suggest? What do they tell us about our clients? Can we identify what is remarkable, what it indicates, and how we can help them? I suggest we can identify 2 factors that make these comments remarkable. Most apparent is that people who arrive with substance disorders seem to be discouraged. I often say they've lost the joie de vivre, the joy of living. Client sitting in a first time in a group with me. Yeah, I get sober, he says, but I have a felony for drug possession. My family won't talk to me. I didn't finish school. I have no driver's license, no car, no money, and I'm homeless. What the F do you expect from me? And I say to him, of course, of course. He's absolutely correct. WTF. No wonder he's discouraged. Actually, his substance use is not his primary problem, is it? How about this? Page 94. Progressive functional deterioration of a physical and cognitive nature. The individual's ability to live with multi-system diseases, cope with ensuing problems, and manage his or her care are remarkably diminished. Do you hear that? It's exactly what he's talking about. Progressive functional deterioration of a physical and cognitive nature. The individual's ability to live with multi-system diseases, cope with ensuing problems, and manage his or her care are remarkably diminished. That's from Johns Hopkins Medicine, 2017. And what are they talking about? Wow, R62.7, adult failure to thrive, is a billable specific ICD-10 CM code that can be used to indicate a diagnosis for reimbursement purposes. This is actually a diagnosis. R62.7 is a billable specific ICD-10 code that can be used to indicate a diagnosis for reimbursement purposes. R62.7 is applicable to adult clients aged 15 to 124 years, inclusive. Johns Hopkins Medicine, 2017. So what we call the loss of the joie de vivre is actually a clinical diagnosis. Adult failure to thrive. Yeah, substance disorder. But inability to deal with the substance as long as we neglect to face the underlying problems which exacerbate substance use. So it's not a coincidence that one of the 12 core functions of an addictions counselor in the state of Florida is case management. SAMHSA's Tip 27 identifies case management as pragmatic. Case management begins where the client is by responding to such tangible needs as food, shelter, clothing, transportation, or childcare. So if a person comes into treatment for a substance disorder, we send them out without a job, without shelter, without a driver's license, unemployable, then we have failed in their treatment. We've treated the symptom, which is the drug, but we have not treated the underlying problem. While it seems that failure to thrive is an obscure concept, SAMHSA suggests that we directly address those overwhelming life problems that lead to failure to thrive. So the question is, are we done yet? No, we're not. Now we observe that our client appears to compulsively engage in behaviors which are injurious to themselves, or self-sabotage, sabotaging anything that is good, including recovery. Some evidence of this. The client said, when I hear someone dies of an overdose, I think we're going to get some of that shit. When someone says, to use is to die, I think, but isn't that the point? When I ask a client how many times have you overdosed, the response is seldom less than one. But the second question, but knowing you died from using, you used again. Matter of factly, yes. Have you ever been revived from an overdose and was angry because they didn't let you die? About half of the people say yes. So we go back to the Perkinson Planner. And in the index, they talk about lethality as one of the co-occurring authorities, lethality, self-destructive behaviors. And if we go back to the DSM-5, on page 804, 803, 804, non-suicidal self-injury. We look further within the DSM-5. We find in the index Z91.5, parasuicidal behavior. But what is parasuicidal behavior? Z91.5 is a billable, specific ICD-10 code that can be used to indicate a diagnosis for reimbursement purposes. Became effective on October 1st of 2018, less than 90 days ago. A personal history of parasuicide. Parasuicide. Personal history of self-poisoning. Self-poisoning, the drugs are self-poisoning. We've already had them say, yes, I know I could die, but isn't that the point? A personal history of a suicide attempt. But let's look at the definition. Medical definition of parasuicide. An apparent attempt at suicide, commonly called a suicidal gesture in which the aim is not death. For example, a sublethal drug overdose or wrist slash. Previous parasuicide is a predictor of suicide. I then refer you to an academic paper by Tuppett Yates, a PhD from California, UC Riverside, Developmental Pathways from Child Maltreatment to Non-Suicidal Self-Injury. The child maltreatment is associated with a range of disorders across both internalizing anxiety, depression, and externalizing aggression and substance abuse. Those remarkably self-injurious behaviors and attitudes are associated with early experiences. Looking at a variety of authors, referenced in my service manual, There are several early experiences which are correlated with NSSI, self-injurious and self-defeating behaviors. And among those are profound or chronic illness, parental loss or deprivation, sexual abuse, physical abuse, early separation from the birth mother. It's important to note here that we're not blaming anywhere. We're merely identifying those experiences which create these self-destructive behaviors so we can more effectively treat them. The young lady who said, when I hear someone died of an overdose, I think about where can I get some of that shit. That young lady arrived home at 9 years old and found that her father had committed suicide. And with clients like that, often at the intake, I look at them and go, WTF, no wonder you did drugs. What else were you going to do? And often they go, yeah, it was the only way I could get by. So now we have to look at how we treat that. What is it that we can do to amend our treatment modalities to address these issues with our clients? Let's go one more time to SAMHSA, Treatment Protocol for Persons with Co-occurring Disorders. And I go to page 207, thick book. It is estimated that between 55 and 99% of women in substance abuse treatment have had traumatic experiences, typically childhood physical and sexual abuse, domestic violence or rape. Of these, between 33 and 59% have found to be experiencing current PTSD. Yet historically, few substance abuse treatment programs assess for, treat, or educate clients about trauma. This deficiency is a serious one. How about models for recovery? Clearly, effective ways of addressing the trauma-specific needs of women with COD are essential. Fortunately, a number of models are emerging. The program must have a commitment to teaching explanations that integrate trauma and substance abuse. I need to communicate to my client that their substance abuse is directly related to their trauma. It reduces the sense of guilt and shame, like it's their fault. I decided to use, it's my fault. The MILU must promote consumer empowerment and relationship building as well as healing. It's not just that I treat you, I need a relationship with you. So those deficient relationships you had in the past, we replace those with nurturing and caring and supportive relationships. It goes on to say that a non-directive but supportive environment is important. Telling someone who's self-injurious, you know, if you do this, we're going to throw you out. They're going to do it because that's what they are. They're self-injurious. As I promised at the beginning of this video, I have come up with specific academically supported solutions to adapt our treatment modalities to better serve our clients. My first volume, Recovery Counseling, the Compassionate Protocols. Interesting, the Compassionate Protocols force the act of loving kindness that we know is the greatest healer. Recovery Counseling, the Compassionate Protocols, is a reasonably thorough, academically supported argument for improving our treatment modalities. It has global interventions as well as adaptations for individually presenting problems. An examination of its contents reveals over 28 topics addressing multiple elements of the clinical process. It also offers a markedly innovative treatment method entitled identity therapy, which aids in producing the spiritual experience or the psychic change so often referred to in recovery fellowships. Recovery 101 is a workbook for persons in recovery, which can be titled and printed for your treatment facility. Each exercise is diagnostic for one or more of the 44 co-occurring disorders. Each exercise comes with a clinical treatment plan with specific clinical treatment goals. These exercises create a process where the client comes to understand, is validated, given specific goals for recovery, and a method of how to achieve these goals. That's my story, and I'm kind of sticking to it. Please remember that Recovery 101, the exercise book, can be branded to your treatment center. Put your treatment center on the front, name it what you like, something that works for you. Each workbook comes with a complete set of treatment plans, both individual and group treatment plans. Each notebook has a variety of articles that are of benefit to the client themselves, gives them information on recovery. Also on our website, you can obtain the WHO Ball. The WHO Ball has 190 probative questions. It's used in group. Catch the ball, look at your thumb, see what it says. When you were a child, what did you dream of being when you grew up? If you could put a warning label on women, what would it say? There's also a warning label for men as well. Can you recall the most loving thing that anyone ever did for you? So the WHO Ball is available on our website, medallionpublishing.com. The only person who enjoys the WHO Ball more than the therapist is the client. So look us up there. At the beginning of this presentation, I suggested more than one adaptation to our attitudes towards substance disorders. Having challenged the term addict, I would now like the listener to consider the idea that addiction treatment is not an industry. It's not an industry. For us, it's a profession. And it is not mental illness, it is mental health. We do not treat addiction. We counsel our clients on how to achieve recovery. You will note my video, Trap Disease, which challenges the disease concept. In Abba and Cohen, the master's level textbook entitled Uppers, Downers, All-Arounders, describes the political and economic use of substances, beginning with the technology of distilling alcohol and the refining of cocaine, which was used to enslave the natives of South America. Without the substance, there is no substance disorder. I would like to close by suggesting that recovery is not just abstinence. It has been termed a spiritual experience or a psychic change. It's not what our clients learn that is so important, it is what they experience in our care. I would also suggest that if you've experienced recovery, you will be much better equipped to engage in the therapeutic alliance, which Carl Rogers suggests is our most important clinical tool. So my final thought to you will be a meme, which attempts to identify that still small voice which speaks to the person in recovery who has chosen our profession. I trust that some will be inspired, while others will be caught curious. Until then, Shubha Shanda.